Hi there. Thanks for inviting me to talk again at the school function, but obviously we're doing it online. So, as I've done previously, the topic that was requested was something to do with medication, the use, abuse, and pitfalls around it, but specifically with reference to adolescents and younger children. And I think, as we've discussed in a previous talk, the problems that affect children are very much similar to what affects adults, but the difference is that it's happening in a brain that is still in the formative stages. So as a result, we are obliged to assess patients, children early on, pick it up early on, and treat early on, so that the likelihood of them needing treatment for longer periods is less. So psychiatric drugs and medication that work on brain function in general are usually designed as a rule to be used over long periods, and therefore their side effect profile is pretty good. Most of them are pretty safe. The difficulty lies in the diagnosis and determining what is an endpoint of treatment. So specifically, when we talk about children and we talk about adolescents, and in terms of medication specifically, we refer to conditions like mood disorders, anxiety disorders, ADHD, specific learning disorders, and in a second tier we talk about conduct disorders, autistic spectrum disorders, and other conditions which don't specifically respond to medication but often need medication to help both caregivers and the children adapt and adjust to their general living conditions. So, what is the commonest thing? The commonest condition for which we are asked to assess children and adolescents for treatment is usually anxiety and ADHD. ADHD obviously is attention deficit hyperactivity disorder, and up until about 20 or 30 years ago, it wasn't that often that it was diagnosed or treated, but in recent years it has become much more prominent, and that's not because the incidence of ADHD has increased. It's because there's a greater awareness amongst parents and teachers about the condition and how it presents and how it can affect the learner in school in particular, but in general in children. So I think the best way to approach this talk is to break it down into the different diagnostic categories and deal with the medication in each one of them. So if we start with ADHD, the first thing to understand is that all the research and trials and studies to date have proven without a shadow of doubt that this is a medical condition. It's nothing to do with diet. It's got nothing to do with bad parenting. It's got nothing to do with environment or socioeconomic class. It's across all categories. What is extremely well proven in most of the data is that ADHD is a genetic condition. What that means is that it's passed on through your genes and your chromosomes, and they talk about a heritability factor of ADHD which is 83%, which is extremely heritable, which means if one parent of two has ADHD, the likelihood that one of the children is going to get it is very high. Often we find in practice that the genetic link is the father, the paternal gene. So you'll often find that a father who presents with their child for ADHD is a person who struggled through school, and perhaps in his day it wasn't that easily picked up, so as a result he's untreated. But he has difficulty later on in life, because the thing about ADHD is that it doesn't actually get outgrown. You just change to a different phase. And in adults, the ADHD is very different in that it presents with emotional difficulties, chaotic lifestyles, incomplete tasks, difficulty holding down jobs, and so on. So in a child with ADHD, all the brain studies and neuroimaging that's done of the brain in children with ADHD have found that there's two fundamental neural pathways. One is dopamine and the other is noradrenaline. So between these two pathways, there is a deficiency of dopamine in one and noradrenaline in the other, and this is what causes circuits in the brain to malfunction and affect the concentration. Just as an explanation of why this is important is, if you talk about learning, there are several stages to learning. The first one is having an attention span. The second stage is being able to concentrate and maintain the attention. The third stage is short-term memory, and then the fourth stage is long-term memory, and then you get learning. So in order for learning to happen, there has to be attention and concentration. And if that's lacking, all the other processes get affected. And as a result, children are often labeled having learning difficulties, or not being as clever as their peers, or not being capable enough. But often this is not the case. So ADHD is a critical condition that needs treatment, because if it's corrected, and it can be easily corrected, the kid has an equal opportunity as everyone else in their class to showcase their academic abilities. So the medication that's used for ADHD fall into two groups. One is the stimulant, and the other is the non-stimulant group. In the stimulant group in South Africa, we've only got methylphenidate, which is better known as Ritalin, which has come under a lot of bad press over the years because of several lobby groups which have tried to paint it in a bad picture. But from a scientific point of view, it is probably one of the safest drugs that you can prescribe for children, provided it's properly prescribed by the right people at the right dosage and timing, and obviously someone who's aware of what the potential pitfalls are. That's the only group of that's the only drug that's in the stimulant group. In the non-stimulant group, the one that's most prominent is something called Strattera, which is a chemical name, and there's a lot of generics now available on the market. But this is a drug that works on the noradrenergic pathway, whereas the stimulant group works through the dopaminergic pathway. What are the problems with these drugs? I think most parents of children who are being treated for ADHD will be aware that Ritalin, the biggest side effect that most parents complain about is the suppression of appetite, and if the dosage is wrong, often they complain that their kids are sort of over quiet and flattened out. Then there's the other one, which a lot of parents may not be aware of what is called the come down syndrome. So as the drug wears out of the system, it causes what is known as a dysregulation of mood, which means the child can become a bit irritable and grumpy as the medication wears off. So these side effects, the appetite effect, the quietening down, and the wearing off of the drug, are side effects that can be mitigated easily if there's a concerted effort at understanding the various symptom clusters in ADHD, and also what we're trying to address, and having buy-in from parents, teachers, as well as the doctors and psychologists that are involved. In ADHD, there are four domains. There's inattention and three domains. There's poor concentration, which is attention deficit. There's the hyperactivity, which is the motor restlessness, and then there's one which a lot of people don't know about. It's called impulsivity. The impulsivity part is the one that causes a lot of the behavioral problems, and often when we have to medicate with Ritalin, for example, the first symptom that tends to settle is the concentration. Hyperactivity comes later, but often if you're not medicating at the right dose, the impulsivity doesn't really get better. As a result, the behavior continues to be a problem. So when you use a drug like Ritalin, you have to know what the correct dose is that gets full symptom coverage. You have to know how long it lasts in the system, and you have to know what is the expectation of the learner at that stage. For example, a lot of doctors to date have been treating ADHD for school. So in other words, they would treat from 8 a.m. to 2:30. Now a lot of learning happens outside of school, specifically social cues, learning how to interact with people, learning basic day-to-day skills, and for that you also require good concentration and learning capacity. So what often happens is that if you only cover during school days, for school hours, the kid doesn't get socially adjusted, and as a result the personality and mood problems and behavioral problems continue to be an issue. So the rule of thumb with ADHD proper treatment is the right dose for the right duration, which is as many waking hours as possible, 7 days a week, 365 days a year. And if you do that from early on and for long enough, there's a good probability that the kid will learn good social adaptation skills, social learning skills, as well as academic adaptation and learning skills. And so the requirements later on will be much less. Remember, earlier you start treatment, the better it is for the kid, because the basics of literacy, numeracy and comprehension happen in the first 3 to 4 years of school. If you leave it too late, they have this situation where they're always kind of catching up with the basics. So it's difficult, even if you treat it adequately later on, for these kids to make up the lost time. So the important points about the Ritalin is the dosage, duration, starting early on, and definitely removing the stigma that's associated with prescription and use of Ritalin. I often tell parents that bring their kids in for treatment for ADHD that their concerns and anxieties around the medication needs to be dealt with, because the problem is really not about them. It's about giving the child the best opportunity to succeed at an academic level and in terms of their careers going forward. When we talk about the atomoxetine or the Strattera, which is a non-stimulant based treatment for ADHD, it is good in only about 15% of children with ADHD, and it's particularly found to be relevant in kids who have more inattention problems and the hyperactivity and the impulsivity. It's a good option, and it is something that takes about 3 to 4 weeks to start working, so it's not like the Ritalin, which works from day one. And the side effect profile is pretty good. There are a few minor side effects like emotional dysregulation. Some kids get very emotional and tearful on it, but otherwise it's a fairly safe drug, and the dosage is weight dependent. It's a once a day dose, and it's a course. Unlike Ritalin, which works on the day you take it, the Strattera needs to build up in the system and continue. So you take it every day, 7 days a week, and it's only an effect that works after about 3 to 6 weeks. Often in children who have difficult ADHD and they don't respond to one drug, we end up using both together because they're complementary. One works on the noradrenaline, the other one works on the dopamine. So if you combine the effect, you get the best combination possible for the difficult to manage ADHDs. There are other medications we use in ADHD, most notably are things like Risperdal or risperidone, which is to assist with the hyperactivity and impulsivity part of the ADHD triad. And then there are other drugs like antidepressants which have some effect as well. But these are for very rare cases where the two main drugs don't work. So the other condition that is common in children besides ADHD is the anxiety disorders. The reason this is important is because again it's very genetic, it's inherited, and usually the anxiety gene is found in the maternal side of the gene pool. What often happens in practice is you'll find that a dad who's had an undiagnosed, untreated ADHD will be attracted to and marry a woman who is slightly anxious and perfectionistic and worries a lot. So you have a child who will inherit the ADHD gene and an anxiety gene. So often you have a child who will have both. And if you don't address both, the outcomes of treatment are poor. So anxiety is a huge topic. I mean, we talk about various categories of anxiety: generalized anxiety, social phobia, OCD, PTSD, and so on and so forth. In children, we see a lot of generalized anxiety, school refusal, problems with adapting to school situations, or when there's problems at home and the child presents with anxiety. They don't often recognize it as being an anxiety, but it presents very often with physical symptoms, things like headaches, stomach pains, urinary incontinence, behavior changes, school refusal. So anxiety is a condition that is genetically predisposed but is triggered by events, so what they call epigenetics, things that happen in a child's life that can make them anxious, and as a result their symptoms present, and when it presents at an illness level, which means there's a chemical change in the brain, it affects their concentration, it affects their ability to sit still. So often it looks like ADHD. There are many times where I've seen patients who are diagnosed ADHD by their general practitioners and put on to ADHD treatment, but they don't get better. But when you actually, probe a bit deeper, you find out that they have anxiety problems. So stop the ADHD treatment, put them on something for anxiety, and they tend to perform a lot better. So the medications that we use for anxiety belong particularly to two groups in children, which are the tricyclic antidepressants and the SSRIs, which are the selective serotonin reuptake inhibitors. The tricyclics are pretty outdated these days, and very rarely are they prescribed in practice, but they're still good, but they just have side effects which we don't particularly like. The SSRIs, in my opinion, are the first line of treatment for anxiety disorders in children, and the principle of treatment up to adolescence is half the adult dose. So generally we give them half a tablet, and most kids with generalized anxiety respond well. You don't have to treat forever and a day. You can treat for 3 months or 6 months. If you combine it with psychotherapy and you teach the child new skills and you allow them to develop confidence, you can actually wean the medication off quite quickly. Those are the most commonly used drugs for anxiety. If you get, and this is not uncommon, but you can get mood disorders in children. And again, these are children who present with disorders like childhood depression, childhood bipolar disorder, and these can often present with behavior problems rather than sadness or depression. And these are not diagnoses that should be made by general practitioners, but rather referred to specialists who deal with child psychiatry, so they can be clear. These are also genetically predisposed kids, and it runs in families. So the important message to bear in mind is that you can get depression in children, you can get bipolar disorder in children, and these are as treatable as they are in adults. So the treatment that's used is very similar to the treatment for depression, the SSRIs, the tricyclics, and very rarely would you have to go to any of the other more adult-based drugs in the pre-adolescent children. In adolescent children, the brain is far more mature and the symptoms become far more adult-like, so as a result, they have a wider range of medication to choose from. The problems with these drugs are, none of these drugs are habit-forming, and that's, I think, one of the questions that all parents want to know. You can't get addicted to an antidepressant, you can't get addicted to Ritalin unless you're abusing it as a drug of abuse. You can't get addicted to Strattera. But if you take it properly for the right amount of time and you incorporate the therapy and the counseling, there's a good chance that these are short-term treatments that can be stopped after a few months. What are the pitfalls? Generally, they're pretty safe. Most of these SSRIs have got a bit of weight gain associated with them. Some kids get a bit drowsy on them, which means you take them in the evenings. But by and large, I think in the first few days of treatment, some kids might complain of a bit of nausea, mild headache. Generally, they're pretty safe. So there's really no long-term or problematic side effects. There are other drugs that we end up having to use in children and adolescents, but these are in very rare cases, usually in cases which involve things like autistic spectrum disorders, and you often get OCD in children. This is not uncommon, and for that the medication is similar but the doses are much higher. The other question that's often asked is what about herbal or over-the-counter preparations for things like ADHD, anxiety and so on in children. There was a study done by the British Medical Council on behalf of the National Health Service, must have been about 8 years ago, where they took all the herbal preparations on the counters at pharmacies and tested them against placebo and active drug, and found that none of them had any significant effect on neurochemistry. So there are certain things like I think it's called IQ, which has the fish oils in them, which have got some beneficial effects on brain function, but they can't be used in the treatment of things like ADHD and so on in isolation. They can be used as supplements. Apart from that, there isn't much that's available on the homeopathic market that has been proven to be particularly effective. One drug that has often popped up, especially in ADHD, because one of the symptoms of ADHD is sleep dysregulation or sleep phase delay, is melatonin. So melatonin is one of those drugs that has crossed the homeopathic allopathic divide, where it actually has some significant effect on sleep regulation. So it's a safe drug to use in ADHD when sleep is a problem. Apart from that, I can't think of any other medication that's particularly commonly used in children, unless it's for very specific, difficult behavioral problems or complicated ADHD or mood disorders. But that's far too rare and specific to be mentioned in a talk on just general medication side effects and pitfalls. So I think that's about it. This is a recorded talk, so obviously we can't do Q&A, but the organizers, I'm sure, will be willing to take your questions and forward them on to me, and I'll be happy to answer whichever ones I can. I think that's it. Thank you very much.